Why have you applied to come to this hospital?
So I've applied to return back to this hospital for registrarship for a few reasons. First being my experiences during internship and residency made me realise that the collegiate relationships are founded on things like respect for one another, striving for excellent patient care, and they provided me and will provide for me in future opportunities for things outside of clinical medicine, such as the research opportunities that I'm currently undertaking, the teaching opportunities for me to continue teaching the same group of students that I do at the moment, and for me to maintain my positions on kind of certain governance committees and boards. Specifically, I wanted to apply for registrarship at this hospital because of the merits of the teaching program that I've seen the other registrars undertake, and seen the pass rates that they were able to generate, and also seen firsthand some of the tutorials and how they're run. And I really think that the specific kind of bedside respiratory tutes and bedside neurology tutes are things that people have found concrete learning from, that I was able to go and be kind of a guest at. This hospital is obviously a tertiary centre, but even among tertiary centres, with specific respect to haematology, which is where I'd like to pursue my advanced training, it has a whole lot of subspecialties that, whilst I may not be able to develop expertise in within the 2 years, the exposure for which would be a boon for my advanced training job applications, I think. And those are the reasons I would like to come to this hospital.
Okay, so that was a good answer. Maybe you could have just highlighted the excellent reputation of the hospital, the quality of care. They put patients first, and also you've been impressed with the terms that you've done and the consultants you've worked with, and you believe that this is a great learning environment. Your intern has been prescribing warfarin at 5 milligrams to an elderly patient with atrial fibrillation and renal failure instead of 0.5 milligrams. You only realised this error on day 7. She now has epistaxis. How would you manage this?
So this scenario, I suppose there's at least a few different parts that need addressing. In the acute setting, I think that patient needs to be managed and stabilised, and specifically with regards to warfarin overdose with bleeding, I would think that we need to cease the warfarin, replace vitamin K and coagulation factors, assess the patient for hemodynamic instability, ask for support if needed in terms of ICU support, quantify the blood loss and replace blood if needed, and I guess, manage this acute problem. And then in terms of the kind of factors that have led to the problem, there's, I guess, things on a personnel level and a systems level that can prevent things like this happening again. On a personnel level, I suppose myself, the intern, and probably the consultant for the patient, and the consultant for the patient should definitely discuss what has happened. This is something that can cause cause some shock to a junior and a registrar, and in the first instance probably should have some kind of debrief process, but not just debrief. I think there's got to be some troubleshooting around why this has happened. I think obviously the staff members are going to be more conscious of prescribing in the days to come, but if they can come up with a specific way to curb medication errors, that would be good. In my experience, this is not this error has happened, but in the oncology term, we realised that the pain medication drugs were something that we needed to keep a very, very close eye on, and so every single day during the paper round after the ward round, we would write a specific note saying what opioid doses patients were on, whether or not they were prescribed aperients appropriately, and a review of how many PRN opioids they were using, to make sure that, one, we were on top of these people's cancer-related pain, and two, we were checking what doses were being required and whether or not things could be weaned. I think a similar approach on a practical level could be applied to things like anticoagulation, especially if this was a term with either a cardiology or otherwise, with potent drugs like anticoagulants. And then on a systems level, I think there would be some use in kind of fulfilling something like an IMS to register this on a governance level for addressing whether or not there were any system side issues that could flag this kind of error, because this has been left a kind of day 7 to aid the practitioners. Obviously, the responsibility lies with the registrar and the junior as well. But if there's anything that can be done on a systems level, say some kind of addition to the eMed system for an alert or something to happen, that would also be helpful, and that could usually be done by a root cause analysis and a governance board implementing some kind of fix.
Okay, so I didn't really like your answer there. If it's your intern, basically you're responsible for that patient because you're the registrar. The first thing you want to do first is check the INR and see, is it high or not? Maybe even though the patient was getting 5 milligrams of warfarin, maybe they're not over-warfarinized. So if it is very high, well then you would then give the patient, depending what it is, but if it's, say it's 7 or 8 or whatever, you might give the patient 1 milligram of vitamin K and see what happens. You don't want to totally reverse them because you want them to still continue on the anticoagulation. I mean, obviously you're going to have to let the consultant know, and you're going to have to tell the patient's family early on that the patient's been getting the wrong dose of warfarin. And an IMS would have to go in to investigate the processes. But there's more involved here. I mean, you tend to have to say, why hasn't anyone been checking the INR? I mean, why aren't you supervising your intern to make sure that work gets done? If it's in eMeds, the nurses should be looking at the INR as well and questioning why. I mean, unless the patient came in on a particular dose and nobody's bothered to check it, but the INR can be done in eMeds to see whether the dose should be changed or not beforehand. So then you have to look at why you have stuffed up, because basically interns may not be familiar with what should be happening with the warfarin, but it's your responsibility to check that the intern's getting it right. So you then have to reflect on your own practices, what's gone wrong here. You weren't aware the patient was on warfarin or not. And you then have to look at how you could do that differently. And it may be that you sit down with your intern and decide that every patient on warfarin has to have a baseline INR and a follow-up INR within a certain time frame, particularly if it's a routine dose of warfarin. If it's a new dose of warfarin, and because patients in hospital often have changes in their medications, they get put on antibiotics that could influence the INR, for example. I wouldn't be talking about painkillers and other things. I'd just be concentrating on this example. Your consultant deems that the patient is safe for discharge, but the physiotherapist is unhappy with this. What are the main issues and how would you deal with this?
So in terms of issues, obviously the first one is patient safety, but another important one is kind of maintaining respect for your colleagues, both doctors and allied health. So the first task is determining whether or not this patient is going to be unsafe and preventing unsafe things from happening to this patient. So it's kind of observing the patient myself and discussing specifically with the physiotherapist what their specific concerns are, and then establishing whether or not that does make the patient unsafe, and whether or not the consultant was aware of what the physiotherapist was saying when they made their assessment of the patient, saying that they were safe for discharge. Some simple fixes are just making sure that the consultant is aware of what the physiotherapist's concern is and seeing if the consultant deems that a concern, and also whether or not I personally think it's a concern. I think I don't think we should discharge an unsafe patient. If it came to the point where I thought, and I agreed with the physiotherapist, the patient was unsafe, but that the consultant thought that they were safe, and it seemed that we both had a clear understanding of what the physiotherapist's concerns were, I think that the kind of responsibility for patient care is the consultant's for the patient, and so with as much support as possible, I'd probably try to affect what the consultant wanted. But I think it's all about communicating, making sure everyone's got the same information available to them for us to make decisions. And I think throughout this, it's kind of important to maintain my relationship with the physiotherapist and have them know that we're not just making decisions that discount their professional opinion, but kind of talk it through and try and have the physiotherapist then understand what our reasoning is.
So this is often not an uncommon scenario. So it'd be good to try and reflect back on a particular patient you might have had. And some of the things to think about is maybe the patient needs a walking aid, maybe they've got stairs at home, maybe the physio is concerned that they're not safe on stairs, or with a walking aid they would be safer. The consultant may not even be aware of these issues. The patient may have come in for a procedure, the procedure's been done, he may not be aware of what the mobility of the state of the patient is. He's just assumed because the procedure was okay, the patient's ready for discharge. So it's important to discuss with the consultant, by the way, were you aware that the physio is concerned about their mobility, and then see what his thoughts are. One of the questions is, has the consultant seen the patient walk, and have you seen the patient walk? Because if you have, you can then either confer that yes, they're pretty unstable, we need to do something, or no, they're looking pretty good now, maybe their condition's improved. And then if they do go home, do they need some sort of follow-up to just see how things are going? It's good if you could come up with an example where you've actually been in that situation and how you've dealt with it. You're in a busy outpatient department seeing a 35-year-old lady with Crohn's disease. You're paged to review a sick patient on the ward with melena and hematemesis. What would you do in this situation?
I was in a similar situation not too many weeks ago, where I was in the gestational diabetes outpatient clinic, and I was called about a patient whose ketones were going up on the ward, and who my intern had called me and said that their blood was acidotic, their pH was 7.01. So in that setting, I apologised to the patient in front of me, and I told them they would have to go back to the waiting room and that I would have to take a call. And then I informed the consultant who was in the next room about where I was going, and that the patient load had been redirected to their rooms, and that the patient was back in the outpatients department. I also, on my way out, let admin know. And then I attended the patient who was in diabetic ketoacidosis on the ward. We set them up on an insulin infusion and got an ICU review at the time, and eventually they were sent back to ICU. That whole process took 1 hour. When I returned to the gestational diabetes clinic, what I realised that I hadn't done and would learn for next time was to tell the admin staff to kind of rebook, if they could possibly, the last patients on the clinic list. But other than that, well, yeah, I just resumed my duties in the gestational diabetes clinic with specific reference to this patient. I think it's a similar process, but obviously the management of melena and hematemesis is going to be different, and I can go into that if you'd like.
Okay, that was a good answer. I guess the only question is, I mean, Crohn's disease can be a serious illness. So if you've got a 35-year-old lady coming in, you just want to make sure they're stable. Yeah. You don't want them having an acute abdomen that you leave behind and then rush off to see another patient. So you've got to check with the patient that they're not acutely unwell. Yes. If they are acutely unwell, well, then you might have to prioritise and get someone else, maybe another registrar, to go see this other patient while you're dealing with this patient who may herself need admission. Obviously, the rest of what you said was very good. You're going to have to let people know, you have to talk to your consultant, you're going to have to apologise to the patient, see whether she can wait or whether she has to be rebooked for another appointment if she's relatively stable. And then you deal with the sick patient on the ward, and then come back, and if you can get extra help, you might get someone who could come to the clinic and see the patient for you while you're otherwise occupied. Give an example of a time when you've had to deal with a frustrated patient and their family.
Recently, whilst on a medical oncology term, I was taking care of an elderly lady who had metastatic pancreatic cancer, which was proven to be refractory to final line immunotherapy, and so was only left with kind of trial options or supportive management and comfort care. She was frustrated that her current quality of life was poor because she had constant abdominal pain and nausea, and was thinking about whether or not she wanted kind of comfort supportive management rather than searching for any trial that could be used as active treatment. Her husband was very enthusiastic that she could be put on a trial and try to find some curative therapies. the patient was asked multiple times whether or not she wanted to have comfort care, and gave differing responses each time, and we noticed that it was usually due to whether or not the husband was present or absent. Eventually we commenced the patient on quite a lot of pain control and antiemetics, and she deteriorated and became quite a lot more drowsy. The husband then kind of redoubled his efforts in trying to convince us to put her on some kind of trial as a last ditch effort. So the task ahead of us was the path was clear with regards to managing the patient specifically, but the husband's concerns and validating his concerns in the midst of his kind of distress and his wife's deterioration was quite difficult. They were from a non-English speaking background, and so the first step was to kind of elicit his concerns, which we did multiple times while the wife was still lucid, do the use of an interpreter. And a lot of it was sitting with the husband and making sure that he kind of understood why we were instituting the medical decisions that we were doing, and making sure that he was supported by his family from China to let them know in a timely fashion to come to support him and to visit their grandmother as well, who was deteriorating. I think that the show of time and the many conversations that I had with the husband eventually proved to be a therapeutic intervention for him in their own right. Towards the end and after she passed away, he expressed to us that he did really, really appreciate that we had spent so much time with him. Eventually, I think he did come around to saying that he understood that and agreed with us that the best thing for her was comfort care, and mainly that he was just struggling with the idea of letting her go, and that in the end he thinks that we did the right thing. But during it was difficult for us as a team, because each time it felt like we were having the same conversation. But I think that our persistence was what really got a good outcome for him, and a comfortable passing for her.
It obviously sounds like a difficult case. Possibly, maybe involving palliative care early. I'm not sure when they came in, but if the wife was giving different information when the husband wasn't there, and then she was giving a separate views when the husband was there, maybe you need to have a meeting to discuss these differences in opinion early on, to say, why are you telling us with everybody present? Because maybe a better understanding of from the husband of what his wife's wishes were could have been arrived at earlier while she was more lucid rather than by default. Describe for us a time when you used your leadership skills to resolve a difficult patient situation.
An example that springs to mind is similar on a recent oncology term. I was taking care of a 22-year-old who unfortunately had developed cervical spine glioblastoma. And so she was a quadriplegic patient, but only at the age of 22 and cognitively intact. She had come in for recurrent febrile neutropenia related to her chemotherapy, temozolomide, and she was always someone who had many barriers to being discharged. She had recently not been re-accepted back at the group home, the spinal group home that she had been discharged from. We addressed her medical issues and saw her through her episode of febrile neutropenia, but it became clear during her admission that the reason that she was no longer welcome back at her group home was due to her mother's preference for her to live on the Central Coast, where there weren't enough facilities for her at her age with her spinal insult. This led to several meetings, which kind of felt to us as though they'd kind of gone around in circles, with kind of allied health, social work, and her mother. And that was the situation when I had come on to the term. So initially I sought to kind of seek information from the relevant parties. So I got, I talked to the occupational therapists, I talked to the physiotherapists, talked to the social worker and to her mother to elicit all the kind of relevant background information that I could. And sat for a long time with the social worker to try and understand what the barriers were to her going to the various group homes that were the options that was presented to us. I sat with the mother several times to elicit what her preferences were. I sat with the patient, obviously, multiple times to elicit what her preferences were for a group home, and realised that there was just a lot of competing interests and priorities, financial, patient safety, obviously, and comfort. What ensued was a series of meetings with all of those aforementioned people present, where I had to, where I felt my role was to curate a fruitful discussion at those meetings, because as I said, there was a lot of previous meetings which hadn't really gotten anywhere, and a lot of it was just kind of, at the meetings, trying to refocus on kind of what practicable steps there were, because there was a lot of mentioning of this is important, this is important, this is important, but what I felt that my role at those meetings was to narrow down kind of on a, like, to synthesize everything that was going on and say, yes, but what's the next step going to be from that particular driver? Eventually, through those meetings, we were able to kind of seek out this specific group home which seemed to be the best match of all those interests, and eventually discharge the patient at day 107.
Obviously a difficult case. You probably could have maybe summarised a bit quicker. Day 107 doesn't sound like a great leadership outcome for discharging a patient. I mean, although there are some patients that are difficult, so whether you saved a couple of 100 days, I don't know. But maybe you could have said something like, we had a difficult patient that needed discharge, who was reluctant to go back to their current accommodation, and the family were looking at alternative options. But I would have been pushing to say that you were able to use your leadership skills to get the patient back to their current accommodation, and then further options were explored down the track. So they didn't necessarily have to stay in hospital, but they had to go back to where they came from, and then an alternative place found in the future, rather than using up 107 hospital day beds.
So don't mention the hospital stay.
No, it's relevant because someone's probably going to ask you, how long did all this take? Because your answer took a long time. So I presume it did take a long time. But because if they did ask you and you said 107 days, well, that wouldn't necessarily sound good either. So you'd have to, if you're going to say it took so long, it'd be nice to say, well, what was the positive out of all that? So my approach to a question like that would be thinking of examples where you've influenced treatment. So for example, your junior doctor might want to order a particular scan, thinking that we need to do further tests to try and work out what's going wrong with the patient. They might want to do a CT scan because the patient's got an abnormal chest x-ray. And you have to sit down and ask yourself, well, what are we going to do with the results of this scan? Is it going to help change our management? If it's not going to change our management, well, then I'd be discussing with the intern, do we really need to do this test? And I'd be talking to my consultant and checking with them, are we going to get anywhere with this test? I recently had a 101-year-old patient who came into hospital with a mild myocardial infarction, was having some problems with blood pressure. The cardiologist came along and wanted to order a tilt table test. And to me, it didn't make sense. What are they going to do with the result of that in this 101-year-old lady? And we discussed with the cardiologist, and the feeling was maybe they weren't going to do anything different, so there's no point ordering the test. Describe a recent patient interaction which shows your ability to create trust, and what steps would you take to develop an effective relationship with your patient?
Very recently, I was taking care of a 25-year-old patient who was dialysis dependent due to some congenital renal disease, and was being worked up for a transplant. He was also a chronic cannabis user, and he had come into hospital due to some upper gastrointestinal bleeding, probably related to a malleolar vice tear from cyclical vomiting. There was a barrier to transfusing him at the normal threshold because of advice given by the renal transplant consultant that any red cell transfusions would limit his, would cause alloimmunization and limit his transplant options. He and his girlfriend were very frightened and agitated, and he was going through cannabis withdrawal and was telling the nurses that he refused a red blood cell transfusion due to what he had been told by his transplant nephrologist. So I was called to see him for this situation. His hemoglobin was 59 at the time. It was quite low. I assessed him, and he was asymptomatic of that level of anemia. And on reviewing his blood results, his hemoglobin was usually in the mid-60s and left as such without transfusion in the weeks preceding at dialysis. He and his girlfriend were very fixated on the idea that he would never find a kidney if he received this one packed red cell. I also elicited from him that he felt as though a lot of the staff at the hospital did not enjoy taking care of him and found him a nuisance, in his words. I explained to him that my role and desire was to kind of help him, and I tried to explain to him the complex nature of the balance that we were trying to achieve with, making sure that he was safe with a replete hemoglobin level, but also trying to kind of avoid compromising his chances of getting a kidney transplant. In talking to him, I was able to also elicit that he had recently had had a death in the family a week prior, and that was contributing to a lot of his anxiety. At that point, he continued to decline the red cell transfusion, and I needed to continue the ward round at that point, and he seemed stable. So I offered that I would come and talk to him again at the conclusion of kind of the working day, because he was going to be in hospital for dialysis late into the night anyway. Upon my return, I think that my show of face was helpful, and that my coming good on my promise to come see him was also a helpful move. And I spoke to him again with his girlfriend about what he stood to gain from getting a red cell transfusion, the dangers of becoming more and more anemic, and eventually he did accept this red cell transfusion. I think that the things that I learned from that about how to create an effective relationship with my patient was to kind of put in the middle that we have the same goals. His well-being is the goal that is focal to what I'm doing, and that I had a good understanding of his complex situation, and that I was trying to make nuanced steps to help him get to where he wanted to be, but also to offer to be there as another human being.
So that was a good answer. I guess in a question like this, what we're looking at is addressing patients' concerns, listening to the patient, explaining any questions they might have. If they're concerned about certain treatments, well, then looking at what's the evidence to support that, and if necessary, involving the consultant, and also communicating with other members of the family if the patient's agreeable. So overall, good answer. Describe a time when you felt frustrated during interaction with a patient. How did you deal with this emotion, both during the interaction and afterwards?
So on a neurology term that I was an intern on, I vividly remember taking care of a patient who presented with bilateral lower limb neuropathic leg pain. And she stayed in for a few weeks to have this leg pain managed by multimodal analgesia and different agents. And the point of frustration for me was that she repeatedly felt as though she was making no progress, and kind of made comments to the team about our abilities and about our capacity as doctors to help, because she did have quite refractory neuropathic pain. Unfortunately, she was also readmitted kind of a few weeks later for the same complaint, and the whole time period and the recurrent kind of being told that we weren't doing our job properly I found quite frustrating. I think we did things right by her medically. I think we gave her trials of medications and saw if there was effect, and then kind of moved on to the next therapies in the correct order. And I don't think we did anything medically erroneous. And I suppose in the moment, the main task was about just maintaining professionalism, kind of remembering in the moment that we're in the job to help her and to offer her whatever options she can, but also to be frank with her about when options are limited and what she can expect prognostically. In the moment, myself and my registrar sat down and talked about this multiple times, about how to curb our frustrations and how to kind of just, still continue to treat her with our best efforts. And that I found really, really helpful, because as the intern, I was usually the first port of call talking to the patient whenever the nurses paged about a complaint. And the registrar was able to kind of, give me perspective in all of it, like, oh, we've got this next drug to try, so we just need to keep talking to her and seeing what her responses are. I think afterwards was when I gained the most from the experience, because then when I treated other patients who would make comments about how they didn't think treatment was working, or they didn't think that we were doing anything, I was able to kind of feel a bit more grounded in my approach from having talked to the registrar, saying, no, we're doing things in order, and this is, and just trying to, what I learned from it was that often we need to explain to patients what the process is, and kind of what their expectations kind of can be if things go well and if things don't go well. And I think I've taken that forward to treating other patients.
Okay, that was a good answer. I mean, obviously, if you've got a frustrated patient, you need to listen to them and try and work out, is there something that you're doing wrong that you could reflect on to change the way you do things? It's important to debrief with your colleagues and your consultants and other people if there are issues with patients, if they're complaining about you or whatever. And then you have to have strategies so you can cope with these frustrations when you leave the workplace. So overall, good answer. So overall, he answered the questions very well. I think he would have a good chance of getting the job in the department. He didn't make any obvious gaffes, like saying he wanted to come here because it was close to work, or he was the best applicant for the job. I mean, he clearly demonstrated good interpersonal skills. He had empathy. He reflected on his practice. He had good communication skills. Or he has. All these are features that we look for when we're deciding on a successful applicant, and he seemed to know his limitations and knew when to ask for help, and he demonstrated good medical knowledge. So overall, a good interview.